So very recently, we've seen some exciting data that came out from KEYNOTE-522, which looked at a preoperative trial of adding pembrolizumab to chemotherapy in patients with triple-negative breast cancer. In this trial, patients received anthracycline with Cytoxan, followed by, sorry, I'm going to go back. In this trial, patients received chemotherapy with anthracycline, Cytoxan, and taxane and platinum, and then were randomized to receive that chemo backbone with or without pembrolizumab, and then patients went to surgery. And what they found was that patients experienced higher rates of pathologic complete response with the addition of pembrolizumab to that chemo backbone, with an absolute difference between the two arms of about 14%, again favoring pembrolizumab in that case. We do have some very early interim analyses from the event-free survival suggesting a trend towards better long-term outcomes in those patients who received pembrolizumab compared to not. Although, again, at that point in time, with just 18 months of follow-up, that did not reach statistical significance. And so we are waiting on longer-term follow-up from KEYNOTE-522 to see if it meets the event-free survival endpoint, which I think most of us think will probably happen given the very strong trend that we currently see. And so I think if that occurs, and pembrolizumab were to become a standard option in the preoperative setting, I think the challenge we'll face is, do all patients need that chemotherapy backbone that was administered in KEYNOTE-522, which is a very intensive chemotherapy regimen, which many of us don't often give. Many of us will omit platinum, for example, and just give anthracycline, Cytoxan, and taxane. So I think we'll need more work to see if we can de-escalate the chemo backbone. I think we'll need to know if patients actually require receiving adjuvant pembrolizumab, which was also done in KEYNOTE-522, where patients in the pembro arm also went on to get 9 additional cycles of pembrolizumab in the adjuvant setting. It did not seem like PD-L1 was a biomarker to predict benefit, at least in terms of pathologic complete response. The benefit was seen both in PD-L1 positives and in PD-L1 negatives, but we don't yet have data to know if event-free survival would be dependent on PD-L1 status or not. So we do need those data to know if PD-L1 will have any predictive ability in the early disease setting. So I think these data are very encouraging and certainly lead us to think that checkpoint inhibition may have a role in the preoperative setting, hopefully soon. We had seen other data from NeoTrip, which had looked at omitting the anthracycline in the preoperative setting. So it just gave carboplatin and taxane with or without atezolizumab prior to surgery for 8 cycles. And the data for pathologic complete response was presented at San Antonio and really showed no difference from the addition of atezolizumab to the platinum and taxane backbone. We don't yet have the event-free survival data to know if the event-free survival will be better in those patients receiving atezolizumab. But at least what we do know is that there was no difference in PCR and that there was no difference regardless of PD-L1 status. And so we don't know why it is that KEYNOTE-522 seemed to be positive and why NeoTrip seemed to be negative. Is it because they used different checkpoint inhibitors? Maybe is PD-1 better than PD-L1? Is it that KEYNOTE-522 used an anthracycline and NeoTrip did not? Is it that anthracycline works so much better synergistically with checkpoint inhibition? And that's why KEYNOTE-522 was positive and NeoTrip was not. So I think there are lots of questions that still remain, but I think the initial signal from KEYNOTE-522 is very promising, and I think there likely will be a role for checkpoint inhibition in early triple-negative breast cancer. In the metastatic setting, I think one question that arises is, what's the optimal chemotherapy backbone to give with checkpoint inhibition? Certainly, IMpassion130 looked at nab-paclitaxel, and I think nab-paclitaxel was selected because it does not require steroid premedication, and there's some thought that use of steroids may hinder benefit from checkpoint inhibition by suppressing the immune response. And so, nab-paclitaxel seemed like an ideal chemo backbone, but we truthfully don't know if there would be difference if we had given paclitaxel, even if steroid premedication was required. And so the Impassion 131 study actually is exploring this question by giving paclitaxel with or without atezolizumab to see if a very similar benefit is seen in this setting, again, with using paclitaxel instead of the nab-paclitaxel regimen. So I think we'll have to wait on that data to see if we can swap out the different taxanes and if the benefit would be the same. But I think another challenge is that, many patients with triple negative breast cancer recur soon after their adjuvant taxane. And so paclitaxel doesn't seem like the ideal chemo backbone in these patients. And so I think we're also looking to see if other chemotherapy backbones may also have benefit with checkpoint inhibition. And Impassion 132 is also looking at this question in patients who have early relapse after their adjuvant taxane and looking at the carbogem backbone or capecitabine with or without atezolizumab. And so I think that will also be important data to have, particularly again when you don't want to be giving a taxane. And certainly Keynote 355 allowed choice of chemo backbone with either carboplatin gemcitabine, paclitaxel, or nab-paclitaxel. And so I think those data will also be very important to flesh out differences in choice of chemo backbone and impact on efficacy. So while there definitely is a signal for benefit of checkpoint inhibition that has emerged from Keynote 522 in the neoadjuvant setting, I think the question will also remain, would benefit be seen in the adjuvant setting? So if someone went to surgery first and then went on to get chemotherapy, would adding checkpoint inhibition to chemotherapy in this setting make a difference? And I think there's some biological differences between administering checkpoint inhibition in the neoadjuvant setting as opposed to the adjuvant setting, where many of us wonder if there could be differences in efficacy, because in the neoadjuvant setting, you still have your tumor in place. And so potentially as you're killing tumor, you're seeing more neoantigen expression and potentially could see a higher immune response. Whereas in the adjuvant setting, the tumor is removed and you're really looking to kill micrometastatic disease. And so it's unclear if you'd see the same sort of synergy between chemotherapy and immunotherapy in that setting. And so there are trials exploring both of these settings. And so Impassion 030 is looking at adding checkpoint inhibition to adjuvant chemotherapy, so taking ACT chemotherapy with or without atezolizumab. And so that trial will help us better understand if adding atezolizumab to standard ACT chemo will improve outcomes. And there's also another preoperative trial that's looking at ACT with or without atezolizumab that has completed accrual that we're waiting on data for to also see if in the neoadjuvant setting with an anthracycline backbone, if adding atezolizumab is having benefit. So again, I think there are lots of unanswered questions that remain, but lots of studies that have looked to address these issues. And so a lot of data is pending. I think in the early disease setting, I'm really hoping that we will see a statistically significant event-free survival benefit from 522. And if this is the case, I think we'd also want to know, is event-free survival different based on PD-L1 status? So hopefully we'll be able to better understand that and see if there are any biomarkers that can help us select patients for checkpoint inhibition in the early disease setting. And I hope in the future we'll be able to see if we can de-escalate the chemotherapy backbone for our patients as we're adding checkpoint inhibition to potentially lessen toxicity.